I want to highlight here that, the Javelin Bladder 100 trial is the pivotal trial that set the stage for gem carbo followed by avelumab maintenance. In the past, we used to treat patients with platinums, and if they had a response, we would just watch them until they progressed and then use immunotherapy. But in the Javelin Bladder 100 trial, patients who had a response or stable disease with platinum-based chemotherapy, when they got avelumab maintenance, their overall survival was improved by 7 months. And that is now the current standard and the premise for using gem carbo followed by avelumab. Now, a little bit discussion about what is platinum ineligibility. So when we talk about cisplatin ineligibility, those are the patients which I mentioned before who can't get cisplatin but could get carboplatin. Now, with these label restrictions, when the category of platinum ineligibility was introduced, there was really no definition. And we initially defined this category based on the consensus survey from 2019 amongst medical oncologists treating patients with bladder cancer, and presented it at our GU-ASCO meeting in 2019. And since then, there has been changes in the standard of care with use of avelumab, and we wanted to redo that survey to see if what physicians think has changed. So we used the same cohort of physicians who had initially provided us responses. And this is what we found, and this is going to be presented at the annual ASCO meeting this year. So we found that 68% physicians thought that ECOG performance status 3 or higher or creatinine clearance less than 30 were good criteria to determine if patients should be eligible to get carboplatin or not. About 53% folks felt that grade 2 or higher peripheral neuropathy is someone they would not offer carboplatin to. 80% people defined NYHA class 3 heart failure as a cutoff, and about 48% people thought that in a patient with ECOG performance 2 creatinine clearance cutoff to be used to define platinum ineligibility would be this. And the rest of the responses were mixed, and this was the most common response, even though it's not more than 50%. So any of these criteria, even if a patient matches one, we feel is a good guidance for physicians to not give carboplatin. And in that case, they can use single agent immunotherapy. But it should be noted that these patients are not that many. It's hardly 10% or so, those who are meeting these criteria. So we should not be depriving patients of carboplatin unnecessarily.